We move on to the second big talking point, and as promised to you on a daily basis, we have the vaccine tracker here with the latest updates. Today we focus about India's vaccination plan, and in fact the center has come up with an exhaustive document of how the things are going to function once the vaccine has got its approval and goes into the rollout stage. Approvals done, production done. How will the rollout vaccination plan work? Now, our team has gone through this exhaustive document of guidelines and we've pulled out the interesting points. We're going to spend some time explaining this to you. This is all you need to know, from logistics to training and execution of the process at the vaccine centers. This is all you need to know about the center's vaccine plan. For example, the center says there will be 100 vaccinations each session. As of now, that's the plan. If logistics allow, maybe we can increase it to 200. The state governments are already fixing the vaccination centers and days. So this will actually be like how you have elections. And on a certain polling day, everybody goes to the polling center to cast their vote. You show your ID, you are registered in a voting list, and then you vote. Similarly, on vaccination days, you will have to be pre-registered with the app. You will go to the vaccination center, you will show your ID, you will get vaccinated. There will be 3 rooms: waiting, vaccination, and of course the observation. So 30 minutes post the vaccination, they will observe you right there at the vaccination center. If you begin to show any severe after effects, you will be immediately hospitalized. But the tracking doesn't end there. The tracking will actually go on for several weeks. Keep in mind, viewers, these vaccines, whichever one gets the approval first or second and comes out, these are newly developed vaccines. We don't still know a lot about them. They've obviously not been tracked for beyond a certain amount of time, beyond a few months. So there may be cases where we don't know what are the after effects. So the government will have to track those who've been vaccinated for weeks together. Now, as we go along, we're going to take more and more information on various aspects. In fact, for some of those, Ayushman is joining me with the details. Ayushman, obviously the first question that we've spoken about a lot is who will get the vaccine first? How does that get decided? Let's start with that.
Well, Tanvi, very important question that is in everyone's mind. So the government has clearly said that there will be priority group. The group consists of healthcare workers, first of all, because they are involved in the day-to-day healthcare activities. After that, there are frontline workers who are there on field. And third, the most important, are the elderly group. And this also has 2 parts. In fact, the elderly population, which has the comorbid conditions, will be definitely given a preference. But after that, it will be elderly population, which consists of the age group above 50 years. So these are the priority groups. So to start, this is a detailed guideline which has been shared with the center. It's called the operational guidelines, which the center has shared with the states, in which, like you mentioned, from A to Z, every query has been answered. And in fact, the preparatory phase as to how the vaccination has to be done, inoculation has to be done at the state level, that has been defined, Tanvi.
Okay, Ayushman, since you are our in-house vaccine expert, I have a couple of more questions for you. How will we identify these priority groups? Is that the responsibility of the state? And what about the vaccination centers? Who sets it up? How will that be done?
First of all, Tanvi, if you remember, the center has written letters to the state governments for the priority group. First of all, it is very important to understand that both center and states have got a very important role in it, and the state will have to prepare the list where it has to create the list of priority group. It will consist of the healthcare workers. In the healthcare workers also, there are separate columns for the doctors, paramedics, and other categories as well. We have seen the Delhi government notifying the website for that, and other states have also started the process. Similarly, in the other functionaries, if you see, the state governments have been told to identify the elderly population. Now, that can be done through the voter list as well as Aadhaar card. That is upon the states to identify. At the same time, for the comorbidity, it is very important to understand that the state health mechanism has to be put in place to identify as to who are the people who are there in comorbid condition, because normally it is very difficult to find as to who are the people who are in comorbid condition. So the center has given this responsibility to the state to identify as to who are those people in that category who need the vaccination at the earliest stage, because Tanvi, the ambition which the health ministry officials have told us remains that the mortality should come down, and once mortality reduces, the breaking of chain of transmission will be important, and that will only lead to the reduction in number of cases. So the state has been given more power to actually calculate the number of people, and accordingly they would be given the vaccine which they have to start the vaccination.
All right, Ayushman, thanks so much for joining us and bringing us all of those details, an exhaustive set of guidelines, and that have been shared by the center to the states. And of course, this is, I mean, essentially, if you read all of it, all our queries will get answered at this point of time basis. What we know. What will not get answered is what will the vaccine, which vaccine will it be? Because we're still waiting for the government to take a final approval. They're considering all the applications. The drug regulator actually is considering all the applications right now. And so that question will get answered later. But I have two more experts who are joining us. Dr. Ramanan Lakshminarayan, Affiliate Professor for Global Health at the University of Washington and Director and Senior Fellow at the Center for Disease Dynamics, and Dr. Anand Bhan, researcher for global health, bioethics and health policy with us. Always good to have both of you joining us. Dr. Ramanan Lakshminarayan, one thing that stuck out was this number that has been put out, which says 100 individuals per session. Now, what does that really mean? On each of these vaccination days that we decided, each center, will it only be these people? What would be the rationale behind such a decision?
So this has been thought through quite carefully, Tanvi, and I think the plan is great to have released at this point because it allows states to prepare. Now, remember that the entire program is going to be run through the Universal Immunization Program, which fundamentally is responsible for vaccinating children. And session sites for children are organized in the following way, which is it's a particular day of the week, a certain number of kids show up, and then they get vaccinated. So they've probably calculated how much vaccine can be taken to a session site, how many people can actually be accommodated with the one person or two people who are handling the vaccination at that point in time. And they've tried to optimize around that because obviously they don't want long lines of 1,000 people and 2,000 people standing outside clamoring for the vaccine. Now, making sure that people are disciplined in following the rules and getting their vaccines is going to be the big challenge. Eventually, there will be enough vaccine for everyone. But I think we need to follow this priority group and follow these instructions very carefully because it's there essentially to ensure there is not overcrowding. The last thing you want is a COVID super spreading event at a vaccine session site.
Oh yes, that for sure would be the last thing, and would be ironic in so many ways. So we have to be extremely careful about that. Dr. Anand Bhan, the other question that emerged was, so we understand how will they identify the priority groups in the sense of people be above the age of 50. That's easier to do. You have your electoral list, you have your Aadhaar database, you know people's age, you can identify them and say. But there is also the other clause which says people with comorbidities. Now, how is any state going to decide that? Do we have available database for that? Dr. Bhan, I think you're on mute. We're not able to hear you.
Sorry. I hope you are able to hear me now.
Yes, we can.
Thanks. Yes, so I think the first group is probably the easiest, health facilities and health workers. Most health facilities obviously have a database of the health workers. If these are formal healthcare workers, which I presume is the focus, then it's easy to do them. As you're rightly pointing out, frontline workers are also going to be relatively easy because there are databases available. The difficulty is actually going to be those with comorbidity because we don't really have a good screening program which is effective across the states. So we don't really have a good handle on number of people with comorbidity. Our estimates have shown, research has shown that it's fairly high. We know diabetes, hypertension is, there's a big NCDs epidemic in the country, which is non-communicable diseases. So to ensure that we actually know who to target, we'll also need some kind of a screening enterprise, either something which is driven mostly locally. So states like Kerala, I think, actually have better intelligence at the local level because they have health workers who do these kind of screenings regularly. And I think that is maybe something we can learn from to try and identify people quickly enough, those who are going to be eligible. But I think one of the challenges from my perspective, besides the fact that not everyone who is comorbid knows that they are comorbid because they've not yet been screened and diagnosed, is the fact that this is slightly different from an election exercise. Obviously, in an election exercise, you only want those who are eligible from an electoral perspective, those who are citizens to vote. But here you're using vaccination for a public health purpose. So irrespective of whether I have a voter card in a particular city, I might be a migrant who's come in from another state. If I am within that eligibility criteria, I should still have an option of getting the vaccine, even if it's a different state I'm residing in, because the purpose is a public health purpose. It's not for me to vote and get someone who's, who is from the local area into political office. It is to ensure that we get more and more people covered by the vaccine, build up immunity, especially, and try to protect those who are most at risk. The third element I have some concern about is the self-registration module under the CoWIN platform. So I think there is also an expectation that you will do self-registration. Now we know that smartphone literacy is increasing, but there is still a digital divide. So unless there are enablers in terms of frontline workers who are going to help those who might not have access to that kind of technology to register themselves, we might have obviously being easier for those who have access to technology, being able to put their information in, and those who don't have access to that that technology not being able to. So hopefully, these are the kind of things that will be addressed. You also need to ensure that people have the ability to travel to centers where vaccination will happen. And, that's where, we don't have a great transport system sometimes from health. For health, we know there are delays with ambulances as well. So hopefully there will also be a way for frontline health workers such as ASHAs to accompany those who might be vulnerable, who might be physically frail, and take them to these vaccination centers and get them vaccinated. So it's not just about the facilities, but also ensuring people get there. And as Dr. Ramanan was rightly saying, ensuring that these facilities don't become centers for risk for transmission.
Yes, well, I think there are also plan as part of the plan for them to have an outreach program to go to people in far off places, to at some point maybe also have mobile vaccination centers. 'Cause like you said, not everybody will be able to get to a vaccination center. The other point that you raised is interesting about self-registration, to what extent can people do it themselves, and one would hope that the government also brings in support staff members who are out there in the field who are helping people to self-register before they can get vaccinated. Now, what do you need? For everybody else to know, what do you need for self-registration? Well, you will have to provide your name, date of birth, permanent and current address, details of your comorbidities, documents that will be needed. So there will be an entire option like it usually is: Aadhaar card, driving license, health insurance smart card, Manrega job card, your PAN card, passport, pension document, service identity card, which would have been issued by either the central government or your state government, smart card by the RGI, or your voter ID. So these are some of the documentations that can be used for self-registration. I'm assuming that one point, like we spoke about Aadhaar a lot, and then we spoke about Arogya Setu app as the next big hub where everybody had to get on and get registered. CoWIN, that's what this cloud-based system is called, CoWIN. CoWIN will become the next big thing that all of us will be sitting and figuring out to get ourselves registered at some point. Dr. Ramanan Lakshminarayan, if you can help our viewers also understand how and what is this CoWIN, and will it become an essential part of our life in a few weeks?
So, Tanvi, I'm actually quite familiar with this platform CoWIN because it's something which I played a role in introducing as even about 6-7 years ago. It was primarily meant for supply chain management on the vaccine side to figure out where vaccines were in the system. We have 20,000 cold chain points around the country, and also to figure out what temperature they were being stored at, because there were many instances where vaccines that were kept at below freezing, which was not good for regular vaccines, or the cold chain was not being maintained. Now, this vaccine platform, which was created by an entity called ITSU, which I used to run, the Immunization Technical Support Unit, essentially has done a great job in carrying this out across the country so that all vaccines are mapped What it has not done till date is really take on the demand side, which is the part about people registering to get vaccinated. So I think there is still a lot of work to be done there, because that is a tremendous exercise. Getting someone registered with all of this is as tedious as getting someone registered for their Aadhaar card to some extent. And of course, delivering the vaccine is more difficult, I would say, than just getting fingerprints and identification of someone. So I think these systems hopefully have been ramped up to a point where they could, play that role. I don't necessarily expect that there will be a lot of fraud in the system with people trying to misidentify to get the vaccine. The one part I am a little surprised by, honestly, is the comorbidity part, because that's going to be, as Anant also said, the most challenging part of the system. Age, Aadhaar will provide, obviously, the healthcare worker part is easy, but this comorbidity part it has some scope for loopholes, and I think that states will have to figure out how to make sure that this doesn't become, a reason why some people get ahead of other people without good justification.
If I can ask you as a follow-up to that, what's happening in other nations? So UK already has rolled out its set of preferences, age group-wise, and comorbidities included. Do they just have a better database of the health records?
Well, people tend to know and have records of whether they have diabetes or hypertension because they've been measured. The vast majority of our population that is diabetic and hypertensive simply does not know that it's diabetic or hypertensive. Therein lies the problem. And even if they were to know because they found out from a local, rural medical practitioner or whatever, there is no paperwork that shows that they were. And these cutoffs have to be determined. I mean, after all, who is diabetic? It has to be sort of a clinical judgment. So there's a lot of work. I think the challenging part here is going to be the comorbidity, which needs to be done well. The other parts, I think the system should be able to deliver. And keep in mind, again, that some states have very good immunization programs. Other states are a little weaker in that respect. So you'll expect to see a correlation between states like, Kerala and Tamil Nadu and Punjab doing quite well on this because they have well-organized immunization systems in place.
Okay, point well taken. My last question to you, Dr. Bhan, before we wrap this up, is also about the need for tracking post-vaccination. And I think a lot of our viewers will not know it or understand. For how many days or weeks will that need to be done? Again, I think CoWIN will play a big role there as a platform that does the tracking of those who've been vaccinated. But why do we need to do that?
Sure. So, typically what we look out for when we do these kind of mass immunization exercises are what are known as adverse events following immunization, AEFI. And what you're trying to look at is because in a clinical trial, you have a controlled environment and you only have limited numbers. Even if you're doing, say, 3,000, 4,000 in a clinical trial, you might sometimes miss an adverse event, which is 1 in a lakh or 1 in a crore, that kind of incidence, right? But when you immunize at scale is when you start picking up those kind of events, and you want to ensure that you are picking them up fast enough and then taking decisions whether there is anything to be concerned about. The other thing, obviously, besides safety is going to be efficacy and better understanding, once people are immunized, are they actually getting infection? If they are getting infection, what is that, what is that percentage like? So I think making that tracking exercise as seamless and as quality as possible would be good. We don't have a great history of doing good quality pharmacovigilance in this country. But it's extremely important to do that, at least for COVID-19, given that we have limited safety and efficacy data right now for these vaccines. The other thing is figuring out if someone were to have an adverse event, how to best handle it. Should they be given high quality medical care at free cost by the government? And should there be a need, shouldn't we be compensating them? Because after all, they have contributed to a public health exercise. And I'm in favor of doing that as well for this particular purpose.
Yes, absolutely. And I think because, it's new, we haven't tracked it for that long. We don't even know how it's going to work, for how long it's going to work, and if at all there are any side effects. I mean, take the example of United Kingdom. They've started giving the Pfizer vaccine already. The UK regulators there have come up with a warning of possible, allergic reactions. And if you do have those kind of allergies, you need to wait and watch to see what happens next. So we'll discover as we go along, but at least the systems are there in place for the checks and balances. Thank you so much to both of you experts for joining us and shedding some more light on this. And viewers, we're going to be putting out a lot more of these details. This is all you need to know right now about the center and the state's plan. Vaccination centers, how will they work, the division within the center, what will be there. It's a very, very exhaustive, detailed plan that the government has actually made and shared with the states now. So we're getting closer and closer to the time when the vaccination process actually begins. It will still be a long time before any of us, the non-elderly, people with no comorbidities can actually get the vaccine. That could take a long time, but at least those who are most vulnerable should be able to get one in the coming few months. And we'll of course keep you posted and updated on all developments. Like I promised you here, every single development related to the vaccine that you should know, you will find out here on the Urban Debate. Thank you to our panelists for joining us on this conversation.